We are live, ma'am.
Yeah. Good evening, dear Facebook Pure Urology viewers. Greetings from Preeti Hospital. Today we are going to hear from Dr. Gyanendra Sharma sir regarding the tips and tricks of supine PCNL. We all know that supine PCNL has gaining popularity in the recent years, and more budding urologists are shifting their trend towards supine PCNL. At least they have some keen interest in getting to learn the supine PCNL because of the various advantages claimed, like the anesthetic advantages, airway safety, cardiac safety, positioning of the patient is less time consuming, so radiation safety to the surgeon, and also the dual endoscopic access availability, so on and so forth. A lot of advantages have been described to its credit, but still many of the urologists are not widely accepting the supine because of the doubts regarding the position, whether we can access multiple tracks, and also the fear of colon, the viscera, etc. So to clarify on all these, we have Dr. Gyanendra Sharma sir. Let me introduce you. He needs no introduction, however. Gyanendra Sharma sir is a consultant urologist at Chittale Clinic Private Limited, Solapur. He has more than 32 articles published in various national and international journals. He is the board member, Indian School of Urology, Academic Wing of USI. He has won the Best Reviewer Award from Indian Journal of Urology in 2023, and he is the member of the editorial committee of IJU. He described the hybrid technique, and that is cited in the Smith's Textbook of Endourology and by the EAU. He has been invited at Tribhuvan University, Kathmandu twice to demonstrate PCNL. His paper on hypospadias is cited in Campbell's Textbook of Urology, 10th edition. He described a novel way to treat chyluria by instillation therapy. His paper on predictive value of the APD of the renal pelvis in supine and prone is published in the Campbell's Urology. He has written at least 9 chapters in urology, and he is the section editor of Pediatric Urology section of USI Textbook of Clinical Urology. And he has also written a chapter, Is Research Feasible in Private Practice? More than 100 presentations in various conferences, as a reviewer of many national and international urology journals to his credit. So with this, I'm handovering to Dr. Gyanendra Sharma sir to take over. Thank you.
Thank you, Saundarya, for these kind words, and it's always a pleasure interacting with you.
Thank you,
It's
sir.
been an honor to be invited by Preeti Hospital to give a short talk on a topic which has been of great interest to me, that is supine PCNL. A lot of people had actually asked me that because I devised a technique for percutaneous renal access in prone position, which is known as a hybrid technique, why did I shift to supine? And the various advantages that you mentioned initially are the basic reasons why I shifted to supine. And in the last 6 years, it has been only twice that I have done a prone PCNL. One was very early in 2020, and the other was to demonstrate it in a workshop. Otherwise, I solely do supine PCNL. Shall I share my slides?
Yes, sir, please.
Yeah. Are they visible?
Yes, sir, your slides are visible.
Yeah, I will make them full screen. Right. And yeah. So my talk would be centered around the basic tips and tricks that I use to do supine PCNL. And the emphasis will be not only to describe these tips and tricks, but also to mention the anatomical and scientific rationale behind these tips and tricks. Now, most of the times I do supine PCNL, except in very young children in regional anesthesia, that is spinal anesthesia. And the first thing that I need is that I do is mark the posterior axillary line and position the patient. So this positioning is a very important aspect which sometimes is not given due importance in a lot of journal articles and textbooks. And these are the aspects that we need to look at. The first thing is mark the posterior axillary line, give the modified lithotomy position, insert bolsters under the scapula and pelvis, confirm on C-arm that the position is perfectly as what we need, and then start painting and draping. Now, how do we mark the posterior axillary line? If you look at a lot of videos as well as articles, not much emphasis again is given, and more often than not, it is done in a supine position. I personally feel that this should be done in an anatomical position, and I will show you few things why I wish to emphasize on this aspect. But before that, let us consider why should we mark the posterior axillary line. Because whenever somebody starts by doing supine PCNL, his immediate worry is he likely to injure the colon? Surprisingly, the first article which mentioned whether the colon is actually retrorenal in supine and prone position was published way back, more than 40 years back in 1987 by Hooper et al. And they found that in the supine position, the colon is likely to be retrorenal only 2% of the times, while in prone position, it is likely to be retrorenal 10% of the times. So when we are doing a supine PCNL, theoretically, we are actually having a five-fold less risk of injuring the colon as compared to the prone PCNL. Now, let us look at some earlier recent data. This is an article which was published in 2021, and they looked at colon and described the position in three different ways. They said, if you look carefully, there are three zones which are marked. One is the line number 2 in the upper part of the figure is at the level of the hilum. Then there is a line which is drawn from both the poles of the kidney. Now, anything which is above that first line, that is the zone which is marked as 1, is called as the anterolateral zone. The second is the posterolateral zone. The first one is the anterior zone. The second one is the anterolateral zone. The third one is the posterolateral zone, and the fourth one behind the kidney is the retrorenal colon. And when they looked at CT scans of 102 patients, what they found was that the posterolateral and retrorenal colon were most frequently present in the upper and lower pole of the left kidney in prone position compared to the supine PCNL. And the risk factors for this particular are old age, lower body mass index, and a thin perirenal fat layer. So if you look at this particular diagram, on the left hand side is the incidence of the posterolateral or retrorenal colon in supine, and on the right side is that of the prone position. You will find that on the right side, you are unlikely to injure the colon either in supine or prone position. But on the left side, the chances of injuring the colon are much higher on the left side in prone position as compared to the supine position. Now, that is why marking the posterior axillary line is important, because if we tend to go in anterior to it, then we are likely to traverse the colon as compared to if we go behind it. Now, this patient is in a sitting position. The picture on the left hand side, your left hand side as you are viewing, is where his back is having some degree of convexity. And the picture on the right hand side is where his back is absolutely straight. And this is more akin to the anatomical position that you can get so that the posterior axillary line is marked. And the third is when he is given a supine or a modified supine position and you are marking it. Now, if you look at all these three lines, you will notice that I will show with my marker that the topmost line is marked when the patient was in supine position. The middle line was marked when he was sitting with his back showing a convexity. And the lowermost line is the line when it was marked with the back straight in the sitting position. Now, why this becomes important is when you look at this particular CT scan. In this particular patient, what I had done, and I have done it in number of patients, that I applied a marker. This is you, if you are able to see this as a marker, this is the marker when we are applying it in the patient in the sitting position, and this denotes the point of the posterior axillary line. But if we tend to mark it with the patient in a modified supine position or not in an anatomically correct position, the posterior axillary line is likely to be marked much more anteriorly. And you can notice that there is a risk of injury to the colon that can occur over there. And hence I emphasize marking the posterior axillary line with the patient sitting with the back absolutely straight. Even today, despite doing so many cases and my team being very trained, I always mark the posterior axillary line myself. And this is why going behind the posterior axillary line is important. Now, the next step is the modified supine position that we tend to give. The advantage of this particular position is that we can do a cystoscopy, possibly even a ureteroscopy with a semi-rigid ureteroscope right up to the L4 level, easily do a flexible ureteroscopy, and at the same time, after painting and draping and passing the ureteral catheter, just shift the position and we are able to have a good percutaneous renal access. Now, another important aspect is that more often than not, most of the people who tend to do supine PCNL, they use a bolster in order to get more space in the flank rather than keeping the patient absolutely supine or flat. There are a number of case series which have been published, but if you look at majority of the people who do supine PCNL, they use some bolster. Now what I have done is I have used thermocol bolsters. Now, what should be the ideal width of these or height of these bolsters? No literature does not mention it, but what I have found with my experience is that if the patient is not too obese and is less than 70 kg of weight, a bolster which is having a height of about 5 centimeter is good enough. But for an obese patient, something which is around 7.5 centimeter is needed. Otherwise, you are not getting adequate space in the flank. This is how the position is given and the bolsters are placed. And you can see there is a lot of space available for maneuvering the nephroscope. Now, the next step is to decide whether the position of the patient is right or wrong. Now, very often what happens is that when we start doing supine PCNL, there is a tendency to go much behind the posterior axillary line, and the torso is given a lot of tilt. The ideal tilt is around 15 to 20 degrees, not much tilt is needed. And the best way to know that the tilt is accurate or optimal or not is have a look at the fluoroscopy. The stone should not overlap the vertebral column, because if it is overlapping the vertebral column, then subsequent fluoroscopy will be very difficult. So this is a small point which I would like to emphasize. Now, in children, sometimes just folding a drape and keeping it beneath the scapula and the pelvis is good enough. I'm showing a small video, and it's an unedited video which shows how do I actually mark the posterior axillary line and give the position to the patient. Yeah. So in a sitting position with the back straight, the posterior axillary line is marked. The contralateral leg is given a proper lithotomy position, and the ipsilateral leg is kept as parallel to the OT table as possible. So the idea is it should not be too high, and that is why you can just adjust the stirrups in such a way that the leg is kept straight. Now the patient is brought to the edge of the table. We have to be careful that the patient is not too close to the edge, because every edge of the table is metallic, and otherwise that metallic bar will cause interference with our fluoroscopy. And then the bolsters are placed beneath the scapula and beneath the buttocks. I usually don't mark the 12th or the 11th rib, because I, over a period, have realized this is just for demonstration purpose that I'm showing these iliac crests and the ribs. But otherwise, I routinely mark only the posterior axillary line. It makes no difference whether you are going subcostal or supracostal. And then you bring the patient closer to the edge, so that even if you have to dip the nephroscope, you are able to do that. But see to it that the bar on the lateral edge of the table is not interfering with your fluoroscopic screening. And then have a shoot to confirm that the stone is not overlapping the vertebral column. If the lower pole is being punctured, as it happens majority of the times, then keep the monitor towards more close to the head end. But if you are puncturing the upper pole, then preferably keep it towards the lower or towards the leg side of the patient. Now, once you have positioned, painting and dripping is done, and RGP is done. Now, here again in RGP, I would like to mention that use a diluted contrast, which is diluted 1:3. That is one part of contrast to three parts of saline. And keep the ureteric catheter closer to the PUJ so that all the calyces are filled. Here, even if the ureteric catheter comes down a bit, it is very easy to reposition it, and even your assistant can do it very easily. But if you keep it in the upper pole, then very often when you instill the contrast, then the contrast may not trickle down into the mid and the lower pole. And why opacification of the lower pole is very important is because more than 80% of the times in supine PCNL, you end up puncturing either the mid or the lower pole. When I was doing prone PCNL, I would puncture the upper pole 80% of the times, but now it's exactly the opposite. Now, as regards the fluoroscopic technique of puncturing, here again, in supine PCNL, there is both bullseye as well as the triangulation technique. Interestingly, a lot of urologists believe that there is no bullseye technique in supine PCNL, but it is very well described. What actually is done is that with the C-arm at 0 degree, you can visualize the PC system, and then the C-arm is rotated beneath the patient, and then a cross table image is taken. You mark the desired calyx, and that point of entry where the desired calyx is marked is the point of skin entry, and you can just go parallel to the OR table and you are able to hit. I have tried this on couple of occasions, but I was not happy, because once you are having the sterile drapes over the C-arm, it is very difficult and cumbersome to rotate it beneath the table. And also, I was not comfortable looking at the calyces with the cross table imaging. So I stick to what I still feel is a much better approach in supine PCNL, that is the triangulation technique. Now, in bullseye technique, let me complete this aspect, that the C-arm is then brought back to 0 degree, puncture is performed, and then if the urine is not returned, then you keep on rotating the C-arm, which again, as I said, is more cumbersome. So I would describe the way I do it, and which I call it as a triangulation technique. Now, basically, if you look at triangulation technique, it basically consists of three aspects. You should know which site to puncture, what should be the angle of your puncture, and how do you assess the depth of puncture. Whether you are doing a prone PCNL or a supine PCNL, these things are fixed. Now, how do you determine the site of skin puncture? So we mark the calyx to be punctured with the C-arm at 0 degree by keeping the needle on the body surface. And that line where it shows, as you can see in the right hand side figure, the puncture will be below the posterior axillary line. Now, what should be the site of skin puncture? Now, either you would be puncturing the lower pole or the mid pole or the upper pole. Now, here I have marked 3 stars, which are showing the lower pole puncture, the mid pole puncture, and the upper pole puncture. And if you notice, they are not in a single line. The lower pole puncture is very close to the posterior axillary line. The mid pole is farther away, and the upper pole is still farther away from the posterior axillary line. Now, why this is important? And this is one such case where I had put in 3 wires because it was a Stagon calculus, and I thought I would need 3 tracks. I could manage it with 2 tracks, but when multiple tracks are needed, it is my policy that I put in glide wires at the same time. And this is what I had picked up from my friend Dr. Pankaj Maheshwari, who had taught me prone PCNL. Now, why this particular angle is different in upper, mid, and lower pole puncture? Because the basic tenet of supine PCNL is we should take advantage of the gravity assisted drainage. And for ease of puncture, the needle should be parallel to the floor. But we need to remember that the kidney is not parallel to the floor in supine position or prone position. If you look at the anatomy of the kidney, it is mentioned that the kidneys are angled 30 to 50 degree behind the frontal plane. And the hilar region is rotated in such a way that the lateral aspect of the kidney is posterior to the medial aspect. So this is the actual tilt of the kidney that you see when the patient is in standing position. So if you are doing a prone PCNL, your upper pole punctures, the track are much shorter. Now imagine with this tilt, if the patient is made supine and a tilt is given with the bolsters, you will still have an area where the upper pole is aligned downwards and the lower pole is tilted more anteriorly. And this is exactly the reason when you are doing a supine PCNL and you are doing lithotripsy of the calculi, you will find that more often than not, the fragments from the pelvis tend to enter into the upper pole. And those urologists who tend to do supine PCNL are not worried about it because from the mid and lower pole, they are very easily able to enter the upper pole and evacuate all the fragments. So this particular figure is something which if we understand, we will understand the concept of having these 3 different marks for the upper, mid and lower pole puncture. Now, again, what are we worried of when we are puncturing? For the lower pole puncture, as far as the viscera is concerned, we are concerned only about the colon. For the upper pole puncture, we are worried about the liver on the right side, spleen on the left side, and pleura on either side, especially if it is a supracostal puncture. Mid pole, more often than not, is a much more safer zone. Now, how do we avoid damage to these parenchymal organs like liver and spleen? And for this, we need to understand that the liver and spleen, they tend to lie posterolaterally at the level of the suprahilar region of the kidney. Now, if you notice most of the sonologists and you look at the sonography textbooks and articles, they will measure the maximum length of the liver in the mid axillary line and not behind the posterior axillary line. So here again is another aspect why this posterior axillary line is important. And because both liver and spleen are positioned posterolaterally at the level of the suprahilar region, this is the point where these organs are having their largest dimension. So if the puncture of the kidney is performed when the patient is in mid or full inspiration, the risk to liver and spleen is increased. So again, this is an important point that when we are making a puncture, I usually more often than not 99.9% of the times would try to do it in end expiration. Now, let me show you some images again to emphasize this particular point. And these are the things which I had done when I was learning supine PCNL by reading all these articles. what I have done here is I have marked the posterior axillary line by putting a marker in that area. Now this is the posterior axillary line, and if we just go beneath it, we are likely to injure the spleen on the left hand side. Now if we apply the bolster, there is a tilt which is obtained, and if we go much behind the posterior axillary line, then we are likely to miss the spleen altogether and the entry to the kidney would be straightforward. Now, here you will understand the difference in the different site of skin puncture that I had initially mentioned. The picture on your left hand side is that of the upper pole puncture. Here, if we are just beneath the posterior axillary line, there is definitely risk of injury to the spleen. But if we go much beneath, so what my rule of thumb is, half to one finger below the posterior axillary line for the lower pole puncture, about 1.5 to 2 finger beneath the posterior axillary line for mid pole, and 2.5 to 3 fingers for the posterior beneath the posterior axillary line for the upper pole puncture. And again, if you see here on your right hand side, if you are just about 1.5 fingers below the posterior axillary line, you can puncture the mid pole easily. This particular CT scan axial image will show very clearly how the lower, mid, and upper pole puncture can be done without risk of injury to the viscera, that is, be it the colon or be it the liver or spleen. This is one more photograph which emphasized the same aspect, and this was a supra 11th puncture which I had done for this particular patient, and you can see how much below it is the posterior axillary line. Now, another worry is when we are doing a supracostal puncture is the risk of developing a hemothorax or a pneumothorax. Now, let us understand the relation of the diaphragm and pleura to the kidney. Now, the posterior, and these are possibly lines, famous article by Sampaio, where he mentioned when he found out that the posterior aspect of the diaphragm, especially the posterior leaves, arches as a dome above the superior poles of the kidneys on each side. What it means is that when we are doing a supracostal access, we are virtually traversing the diaphragm in all cases, which are supracostal puncture, and at times even the pleural recess where the visceral and parietal pleura are fused with each other is also traversed most of the times. So what is the key anatomical rule we need to remember? We need to remember that the parietal pleura crosses the middle of the 12th rib posteriorly and the 11th rib at the posterior axillary line. Now, if at the posterior axillary line, we know that the pleural reflection is highest at the level of the 11th rib. So any puncture at or above the 11th rib at the posterior axillary line risks entering the pleural cavity. But if we are much beneath it, then we are unlikely to cause a significant damage to the pleura or the lung. Right? And again, regardless of anything, two things are important. Try to make the puncture in expiration only. And secondly, avoid going supra 10th. That is, do not go above the 10th rib. Once you have decided the site of skin puncture, the question which is very often asked is, which calyx would you puncture? The posterior calyx or the anterior calyx or anything will do. Now in prone, the standard teaching is always puncture the posterior calyx. And the reason why we say that is because it passes through the relatively avascular broodal zones and it gives you a direct path to the renal pelvis. Because if we are trying to puncture an anterior calyx in the prone position, there is increased risk of injury to the vessels, liver, spleen, and it causes a very acute angle which may result in a lot of torque and damage to the parenchyma. But if you look at a patient in a prone position, and this is a CT scan axial image which shows a patient in a prone position, you would very much appreciate why puncturing the posterior calyx is mandatory. But imagine the same patient in a supine position. This is the patient lying absolutely straight. Here you would feel that anterior calyx would be more easier to puncture. And suppose you tilt this patient by giving bolsters, you have access to the anterior or the posterior calyx. So you look at the calyx, which will give you the best access, and you puncture that irrespective of whether it is the anterior or the posterior calyx. Now have a look at these MR urography images. The topmost image is when the patient is absolutely supine. Here you are able to look at only the one set of calyces. But as a tilt is given or about 20-25 degree of rotation is done, you will notice that both the group of calyces, the anterior and posterior calyces, are looking directly in front of you and you are able to puncture it. These particular images, which are reconstructed images of CT scan, also emphasize the same point and also bring to your attention the fact that the upper pole is having a tilt as compared to the lower pole. Now, which calyx should not be punctured? Now, if you look at this particular RGP, you can see all the calyces very clearly. Now, if the patient is given a modified supine position, you can puncture all calyces except two calyces which should not be punctured. One is the upper pole medial calyx, and the second is the medialmost calyx of the lower pole. The position of the patient is such that the medialmost calyx of the lower pole is extremely difficult to puncture, and more often than not, you would puncture the infundibulum and not go through the fornix. While the upper pole medial calyx, the risk of injury to the posterior segmental artery is prohibitively high and should be avoided. So, barring that, depending upon the location and volume of the stone, you can puncture any of the calyces. This again, I am showing the same thing that of the lower pole calyces, you puncture the lateral calyx, not the medialmost calyx. Now, once you have determined the calyx to be punctured, the site of puncture, the next step is angle of puncture. The angle here is very simple. You need to be parallel to the floor. Go in, and then small degree of tilt may be needed if you are just anterior or posterior to the calyx. Now I am showing you an unedited video of the puncture being made. On your left hand side is the surface view and on the right hand side is the fluoroscopic view. So if you see I have marked the needle on the surface of the patient and decided that the lateral calyx of the lower pole is one which I would puncture. I am just going half to one finger beneath the posterior axillary line, making a small nick with a 11 number blade, and I am going in parallel to the floor. So the site and angle are clearly defined. And if you notice, I am having some interference with the rib because I am so close to it. So I have just going to readjust my needle and go in. Now, as you grow close to the gerotas, this movement of the kidney due to respiration is avoided. And you can appreciate on your right hand side that the calyx is getting indented. Now, once you have punctured the calyx, stop at that particular time. Remove the stellate and you will have a free flow of saline which is coming. On your right hand side, you can even see that the glide wire, once it is passed, more often than not, is able to enter from the pelvis into the ureter very easily. Interestingly, about 20% of the times I even get the wires coming out of the urethra. So you have a through and through access which is available. And the dilators are again passed. So once this puncture is made, Then comes the biggest question, which is asked by every newcomer. How do we assess the depth of puncture? So we have looked at the site of puncture, the angle of the puncture, and then we come to the depth of the puncture. The principles are the same. Whenever you want to make the medial and lateral adjustment of the needle, the Siam should be at 0 degree. But if you want to make the antero-posterior adjustment, the Siam should be tilted to 30 degrees cephalocaudally. Now look at the picture on your left hand side. The needle is seen superimposed on the calyx. Now we are not sure with the Siam at 0 degree whether the needle is inside the calyx, whether it is above the calyx, or whether it is below the calyx as is depicted in the figure on your right hand side. Now for knowing the depth, you need to tilt the Siam craniocaudally. Remember one simple mnemonic which I often say कि जब तकलीफ में हो तो माँ बाप की याद आती है, बाप को याद कर लो. If your needle is below that calyx, you are anterior. If your needle is above that calyx, it means you are too posterior. I will wait for a few seconds on this particular slide. Have a look at the figures on your right hand side. The needle is above that particular calyx. Above means posterior. And the lower figure, the needle is below that calyx. Below is anterior. So बाप को याद करो. Below is anterior and above is posterior. These are few images which I have purposely put to re-emphasize this particular aspect, because this is the aspect, whether you are doing a supine PCNL or a prone PCNL, people find very difficult to understand and get unnecessarily make it too complicated. See, the Siam is tilted cephalocaudally, and on your right hand side, you see that the needle is above that calyx which you want to puncture. So above is posterior. So look at the figures on your lower half. The needle is below, that is posterior to the desired calyx. And you have to leverage your hand downwards so that the needle comes anteriorly, and then you are able to puncture. Now, what is the surest evidence that you have punctured the calyx? You will notice an indentation of the calyx. And once you have punctured it, you will have a free flow of saline. Now, a lot of people emphasize that they do a monoplanar puncture. They don't need to tilt the Siam in the cephalocaudal direction. This comes from years of experience by the muscle memory that they develop. But my suggestion to most of the urologists who are starting PCNL and have not reached that level of expertise is there is no shame in going close to the calyx with the Siam at 0 degree, tilt the Siam cephalocaudally, confirm the depth of that the angle of your depth is perfectly aligned to the calyx, and then make a puncture. It does not take more than 30 to 45 seconds to do this, but by this simple maneuver, you are able to avoid repeated poking the parenchyma of the kidney. And of course, remember that you should be bit away from the calyx when you are making these adjustments. Otherwise, your needle should not be in the parenchyma, but it should be bit away from the parenchyma. Now, once you have punctured it, the next step is to enlarge the tract and cut the fascia. But are we really able to cut the fascia? As I had mentioned much earlier, that majority of the times we are making a lower pole puncture, and I honestly believe by using the 11 number blade are not even able to reach the Gerota's fascia. But still we don't face a lot of problem in dilating the tract, because the Gerota's fascia is not so thickened in the lower pole as compared to the upper pole. Now, what are the difficulties which we encounter in dilating? And the important question is, when we are dilating, more often than not, we keep the Siam at 0 degree. So how do we know that our dilatation is progressing in the correct plane? And again, whether you are doing a one-step dilatation, a sequential dilatation, or balloon dilatation is a matter of choice. Honestly, it makes no difference whether you are doing a supine or prone PCNL and which type of dilatation. My suggestion would be you follow what you are most comfortable with. But what I want to emphasize here is, how do you know that your dilatation is going in the right direction or not? Two important principles. As you progress your dilator into towards the kidney, your forward rotation or forward movement of the dilator should be two-thirds by rotation and one-third by force and not the other way around. I will repeat it. It should be two-thirds by rotation and one-third by force, because if you apply too much of force, then you are likely to cause more damage to the parenchyma. And remember that the moment you encounter difficulty, follow what I call it as the glide wire friction test. Now, if your angle of the dilator is perfectly aligned in the direction of the wire, then there will be no friction. So the moment you are encountering some difficulty in dilating, it means that there is some kink of the glide wire which tends to occur. Now, this particular video will show you. Now, if you move this glide wire and your dilator is perfectly in line, you are able to move the glide wire without any friction. But if the angle of your dilator is wrong, then there will be friction. And for beginners, it would be my strong suggestion that after going for every couple of 1 to 2 centimeter, you move the glide wire to confirm that you are going in the right direction. Now, a question which is I have been asked very often is, are you bothered by the hypermobility of the kidney during puncture in supine PCNL? Yes, it is a problem we all face, though it is not something which is very cumbersome and makes the dilatation or puncture very difficult. This hypermobility tends to occur basically because of the lower perirenal fat. So in thin patients, you are likely to encounter it much more, and likely to encounter it much more for the lower pole puncture as compared to the upper pole puncture. So for this, certain simple tricks are: apply abdominal compression with the surgeon. Meaning either you do it or ask your assistant to just put a hand in the midline. Or as I said, if you are lucky, your guide wire comes through and through, comes out of the urethra, you hold the guide wire or let your assistant hold it. So the movement of the kidney is reduced. Very rarely, if the hypermobility is preventing proper dilatation, place a urethral access sheath in a retrograde fashion. And an interesting thing is that if you use a smaller caliber renal access sheath, which is less than, say, which is about 16 or 18 French, then the renal mobility is much less as compared to if you end up putting 24 or 26 French sheath. There are a couple of more things which I would like to mention is, I would just stop sharing. Go by. One is regards the lithotripsy of the calculi that you tend to do. As I mentioned initially also, that when you tend to break the stones, many times the fragments tend to go in the upper pole, but you are able to retrieve them very easily. Don't apply too much of force. Usually, it is very rare for me to ask my assistant even to flush saline from the ureteric catheter to evacuate the stones. By gravity assisted drainage, you are able to evacuate the fragments very easily. Often people believe that it is not possible to do an upper ureteric calculi in supine PCNL. I believe that it is possible, but very often you end up requiring an upper pole puncture or a mid pole puncture for it, and more often than not, it is supra 12th or supra 11th, but it is possible. So, Saundarya, these are few practical aspects which I have learned over a period of time, and I thought it was worthwhile sharing with everybody. I would be happy with any questions if they are from your
Yes, sir.
side.
So it was a really excellent, crisp, very, very clear presentation, and any beginner would actually feel very helpful on seeing your presentation. I would suggest everybody who starts Supine PCNL to see your video and then start doing it, because it gives us so much clear interpretation of the Supine PCNL, sir. Thank you very much. I have some questions from my side, and I'm just looking like
Sure.
if any of the audience. So, sir, for the upper pole puncture, upper calyx puncture, uh, is do you have any particular scenario in which you would prefer prone over supine?
Uh, Initially, when I started supine PCNL, yes, when there was an upper calyceal puncture, I was very hesitant. But over a period of time, as I told you, in last 6 years, I haven't done, and I do upper pole punctures. Even there, I showed you a picture also, which was a supra 11th puncture. So luckily, I have not encountered any collection in the thorax.
And do you do?
Another small thing which I can mention here is that suppose you end up doing an upper pole puncture and you are really worried at the end of it, have you caused some collection? There is another small trick that I can suggest is that bring the sheath out. Bring the sheath out of the renal parenchyma, and while you are withdrawing, because more often than not we are doing a tubeless PCNL. So bring the sheath out of the renal parenchyma, and through the sheath you inject contrast and remove the sheath. Now you can keep a glide wire for safety purpose while you are doing it. Now when you inject a contrast, if you have violated the pleura, then on fluoroscopy you are very easily able to pick up on the whether the contrast has entered the chest. But otherwise, I think if you are not worried about pleural violation in prone, follow the same principles. You need not worry in supine also.
Yes, sir. So actually, like one, even if it is a medial upper calyx, so you don't feel any difficulty in doing the supine one.
Medial most upper calyx I never puncture. It is always the lateral calyx which I will puncture,
Yes.
because from the lateral you will be able to enter the medial calyx
Yes, yes,
with the
sir.
tilt over.
Yeah.
But one contraindication is never ever the medialmost calyx. If at all there is a small stone,
Yes.
worst come worst scenario, you are not able to reach it. You can do ECIRS and reach that medialmost calyx, which will be straightly aligned to the ureter.
Yes, sir, that's very true. So, in all your supine PCNLs or whenever you contemplate ECRS, do you keep the access sheath at the beginning itself, or you place a ureteric catheter, finish your PCNL part, and then, if necessary, you keep an access sheath?
Yeah, I usually, there have been only couple of occasions when I had to do a combined procedure, but I don't put an access sheath because you can say it is probably my confidence that I would prefer clearing everything by PCNL, and very occasionally I would need a flexible approach from the in a retrograde manner.
Yes, sir. So, if we keep the ureteric catheter sometimes or even many times, because the lower calyx is anterior in supine PCNL, the contrast doesn't enter and the desired lower calyx does not get opacified many times.
Very
So,
nice question. See, Sandhya, right at the beginning, I mentioned that when you are doing an RGP, when we put a ureteric catheter, it is our tendency we put it in the upper pool. But when you start doing an RGP, I retract the ureteric catheter, bring it to the level at the PUJ, because otherwise only the upper pole calyces get filled up and the lower pole calyces are not getting filled up. So retract it. Sometimes even if it comes below it, you want to reposition, you can very easily pass a glide wire and reposition the ureteric catheter. But I bring it back close to the PUJ and then only instill contrast.
So, and you were telling about puncturing the like supracostal puncture doing in expiration. So, in case during expiration, the kidney moves up a lot and comes to the 10th intercostal space.
Yeah.
On vice versa, if it inspiration, it can come a little down. So, which one would you prefer, and which is your suggested practice?
This question is to a large extent more theoretical rather than a practical issue. theoretically, if ever there is a situation where the puncture is going supra 10th, I would not do it. Because then I know, worse come worse scenario, if there is no option left, whether it is inspiration, expiration, it is supra 10th, but I don't have any choice, then I would be mentally prepared that I will have to put in a chest tube. But 99.9999% of the times, you are able to puncture the lateral upper calyx by a supra 11th approach. If at all, let me answer that theoretical aspect, then a limited inspiration is fine, but not a big inspiratory effort. See, sometimes I do it and I ask, because most of the times I do it in spinal anesthesia. So I ask the patient to take a inspiratory effort. And if by that inspiration, my puncture is becoming subcostal, then I'm not worried. But as you are mentioning that if the puncture is supra 10th and a little amount of inspiration can bring it supra 11th, I would definitely do it. But if I have done that, I would be more worried of checking whether there is collection in the pleura at the end of the procedure.
So, and sir, we regularly do supine PCNL, like at least for the past 5 to 6 years we are doing. But there are occasions we face difficulty, and we felt that prone would be better in this case. One such scenario is like if the kidney is too much, the pelvis. Suppose if it's a pelvic stone and that is too anterior, or there is some kink in the ureter which causes more anterior, the stone is more anterior and the skin to stone distance is also quite high, it is a very deep kidney, then what happens, our amplage sheath becomes vertical like this rather
Right.
than a horizontal. So if it becomes vertically up, all the water is draining out and the pneumatic lithotriptych doesn't function effectively anti-gravity, the system doesn't distend, so it takes long time. So how to circumvent this problem?
That's a very good point that you have brought, which a lot of people initially are worried of, that whether the system collapses during supine PCNL because the fluid is draining very quickly. And as you mentioned, if you are angling it too anteriorly, then the fluid drains very quickly. Now, this usually tends to occur because we, more often than not, when we are starting supine PCNL, tend to puncture the lower pole too dominantly. Now, if you are having a large stone in the pelvis and you find that the track is likely to be very long in from the lower pole puncture, you can go from a mid pole approach also, and that track would be bit shorter. Again, I would say that we, when we read a lot of articles and books, it is mentioned that the track is longer in supine PCNL. Yes, it is possible that it is bit longer as compared to prone, but believe me, I have been doing even obese patients who are more than 120 kgs, and I very rarely require a 20 centimeter long amplast sheath. More often than not, it is the 16 centimeter. Yes, there are occasions when there is a stagon and I have gone through the lower pole. I prefer a 20 centimeter sheath because when you want to reach up to the upper pole from the lower pole, you require those additional 3 4 centimeter, and where that 20 centimeter sheath is useful. Coming back to your aspect that you tend to have a lot of angulation to your sheath, you try doing the way which I have mentioned, that you be closer to the posterior axillary line and you mark the posterior axillary line in the sitting position, and then you start doing it, you will find more often than not that angulation is not much.
Yeah, this particular case had hepatomegaly, sir. So we could not access the middle calyx. It was too big and we couldn't come closer to the posterior line. We had to go more medially and
Yeah, so
posteriorly.
these are exceptions. Like I have done a case where there was massive splenomegaly, and I used an ultrasound guided puncture along with ultrasound and fluoroscopy. But there I had an advantage that when I did it in this modified supine position, the spleen was far more anteriorly, and I could have the puncture very easily.
Okay, sir. So there is a question from the audience. Dr. Suraj has asked, does ultrasound guidance help to know the bowel interposition during the puncture, or it's only fluoro guided we should be doing?
No, you see, it is a matter of personal choice. I do only fluoro guided, though my wife is a radiologist. I have taken her help only on two occasions. One was this case of splenomegaly, and the other was ectopic kidney, which was situated lower down. And I was worried whether colon is going to come. So my personal experience as far as ultrasound guided puncture is concerned is restricted to only these two cases. And once my wife comes, she guides and does the puncture more than I would do. So I see it is a matter of how you are trained and how comfortable you are with a particular modality.
Yes, sir. So that's true, sir. And so thank you very much, sir. All the questions you have answered very elucidately, and thank you for spending your time. Despite your being unwell, you have taken time, taken so much pains to prepare this presentation and deliver it effortlessly and effectively. Thank you so much, sir.
Thank you, Soundarya. I hope people like it. And I sincerely feel that with the incoming technologies like more and more ECIRS and even the robotic approach for endoscopic surgeries, supine PCNL would be more in alignment with the newer technologies as compared to prone.
Yes,
Thank
sir.
you so
That's true.
much.
Thank you, sir. Thank you very much, sir.